I would like to thank the organizers for the invitation to talk about our work on complement periodontal disease. This is a long-standing collaboration with John Lambris of Penn Medicine and more recently with other collaborators, Hasturk from Forsyth, Dimitris Mastalos of Democritos, and Despina Yankopoulou from Amindas Pharmaceuticals. So periodontal disease is a dysbiotic inflammatory disease that affects the tissues that surround and support the teeth. With periodontal disease, there is a loss of tissue attachment to the teeth. There is a deepening of the periodontal pocket, and the hallmark is the loss of alveolar bone, the bone that supports the teeth, and this might lead to tooth loss. In its severe form, periodontal disease affects 10% of the adult population. In fact, it is the sixth most prevalent condition worldwide, and it has a tremendous expenditure, both in the USA and Europe and elsewhere in the world. Dysbiosis of the periodontal microbiome drives inflammation, but inflammation feeds back into the dysbiosis because inflammatory tissue breakdown products are used as nutrients by the dysbiotic microbiome. So this enhances their growth and persistence. So what actually drives periodontal disease are these reciprocally reinforced interactions between inflammation and dysbiosis. So it's this vicious cycle that is the actual driver of this oral inflammatory disease. Periodontal disease is also associated with systemic inflammation, and this is mostly because periodontal bacteria may get access into the circulation. So these bacteremias that are quite frequent, and they can happen either in the dental office with professional dental care like scaling, tooth extractions, etc., or during daily activities like when flossing or brushing or eating hard foods like an apple, for example, creates bacteremias and systemic inflammation. This is the reason why periodontal disease is associated with increased risk of certain systemic comorbidities, for example, cardiovascular disease, arthritis, Alzheimer's disease, and others. Our lab has recently described a novel mechanism that can mechanistically explain the association of periodontal disease with comorbidities. In the model we used, we investigated the association, the causal association between periodontal disease and arthritis. And we have shown that systemic inflammation associated with periodontal disease causes epigenetic inflammatory memory in the bone marrow, which leads to hematopoietic stem cells being trained in a manner that they acquire a myeloid differentiation bias, leading to increased production of myeloid cells with increased inflammatory responsiveness. These trained myeloid cells populate not only oral tissues where they exacerbate periodontal disease, but also extraoral tissues like the joints where they can exacerbate ongoing arthritis or contribute to the initiation of arthritis, of course, when other risk factors are present. So from this short introduction, one understands that there is a strong rationale for host modulation therapy in periodontitis. As I said, periodontal disease represents a significant public health and economic burden. The current standard of care is not always effective. This mostly involves mechanical debridement of the biofilm, sometimes in conjunction with antimicrobial approaches. And as I said, it's not always effective, particularly in highly susceptible patients. And also the standard therapy does not prevent disease occurrence. And lastly, and very important, there is increased risk of systemic comorbidities for patients that have periodontal disease. This is another schematic that shows the vicious cycle that connects the dysbiosis of the microbiota, and inflammation that leads to periodontal disease. And in a series of articles that we published in collaboration with John Lambris group, we have shown that complement activation is involved both in the dysbiotic transformation of the microbiota, but also in the destructive inflammation that leads to inflammatory bone loss in periodontitis. Th17 cells are also important effectors of periodontal tissue destruction. And in recent publications, we have shown that complement activation is required for the expansion of Th17 cells. This is because complement activation induced by the dysbiotic microbiome induces the production of cytokines, IL-6 and IL-23, which are required for the induction and expansion of the Th17 cells. So we see that C3 is important for induction of periodontal inflammation. C3 is also the central component of the complement system, so it is a rational target to treat periodontal disease. But of course, we needed to get proof of concept for this. And initially, we worked in mice, and we used C3 deficient mice. And regardless of the model we used of periodontal disease, we saw that C3 deficient mice are protected against periodontal disease. In the oral gavage model, the mice are inoculated with human periodontal pathogens. And as you can see, the C3 deficient mice are developing very little, if any, bone loss compared to wild type mice. Same with the ligature-induced periodontal model, where a ligature is placed on molar teeth, and that results in rapid accumulation of dysbiotic bacteria that drive the disease. And C3 deficient mice are also protected from naturally occurring periodontitis. In this model, the mice are not treated with anything. They are just led to grow to old age. And like humans, old mice, when they are wild type, they develop significant bone loss. But as you can see, their litter-mate C3 deficient mice are protected. So we have seen that we can protect mice from periodontal disease, but our ambition goes beyond that. And we set out with John to treat human periodontal disease. So John is an inventor of complement inhibitors, and one of which inhibits the activation of C3. AMI-101 or CP40 binds C3 and blocks its activation by convertases. So the idea was to use AMI-01 to block the activation of C3, and of course to inhibit downstream inflammatory pathways that can lead to periodontal tissue destruction. AMI-101 is exquisitely specific for C3 of humans and non-human primates, so we could not use this drug in mice, but we started with non-human primates. In the first study we performed, we used the ligature-induced periodontitis model in young monkeys. That was a split mouth design. One side was treated with AMI-101, and the other was treated with a scrambled control. The sites that were treated with the drug developed significantly less clinical inflammation, as you can see by reduced probing pocket depth, reduced bleeding on probing, and reduced gingival index. All these are clinical indices that are used to monitor periodontal disease in human periodontal patients. Perhaps the most important finding was that the sites that were treated with AMY-101 developed significantly less bone loss, and this was determined radiographically. In another study, also in non-human primates, we treated older monkeys that had naturally occurring periodontal disease. And also in this case, and this is just some of the data, here is a clinical picture. You can see the inflammation in the gingiva, and they are swollen and reddish, and you can see that they look much healthier after the treatment. Here you can see that the probing pocket depth was significantly reduced after treatment, and even after we discontinue the use of the drug, the monkeys were much better off than when they started. We also analyzed inflammatory mediators from the gingival clavicular fluid. You can see significantly reduced levels of IL-17, potent pro-inflammatory and prosteoclastogenic cytokine, and also reduced levels of rancol, which is the a potent osteoclastogenic factor promoting osteoclastogenesis and bone loss. So we started working in mice around 2011, and then we finished studies in the non-human primates. In 2017, AMY-1 had a successful phase I clinical trial, and in 2019 we obtained FDA approval for a phase II study. Nothing happened during 2020 due to COVID, but in 2021, we completed a successful phase IIa trial, which I will discuss right now. So this phase II clinical trial was performed at the Forsyth Institute in Boston. The principal investigator was Dr. Hajishengallis, and that was under the sponsorship of Amintas Pharmaceuticals. What was used was a split mouth design. One half of the mouth received a local administration of AMY-101, and the other half was treated with a placebo. There were 3 treatments at baseline, day 7 and day 14. And the individuals that participated in the study were monitored until day 90. The key efficacy measurement involved to monitor changes in gingival inflammation, and this was measured by the modified gingival index and also by bleeding on probing. As you can see, the clinical inflammation as reflected by the gingival index was significantly inhibited in sites that were treated with the drug. That was obvious from day 21, but this protective effect persisted for several weeks after completion of the treatment, and at least 19 days after the initiation of the treatment, the treated sites had significantly less inflammation than untreated sites. At day 28, that was the primary outcome measure. And as you can see, there was a huge difference between treated and untreated sites. Similar results were obtained when we looked at bleeding on probing. As early as 21 days, there was a significant difference that was persistent until day 90. So our next step is to perform a phase III trial, and we hope that based on the promising data we have, that this is a transformative treatment that can find application for the treatment of human periodontal disease. In fact, the use of complement inhibitors may not be useful only for periodontal disease, but also other oral inflammatory diseases that are driven by complements. And in that regard, we think that ME01 is a good candidate to treat peri-implantitis. That is the destructive inflammation that also leads to loss of bone and that develops around dental implants. This is a huge clinical problem, and there is currently no treatment. So I would like to thank my collaborators in these studies, John Lambris, with whom we started collaborating more than 10 years ago, Dimitris Mastelos from Democritus, Despina Yangopoulou from Amitis Pharmaceuticals, Katis Hastor from Foresight, and also for our non-human primate studies in the Philippines. I would like to thank Ranilo Rezuelo and Joel Duplano from the Secombrec facility that where the studies were performed, and our collaborators at Manila Central University, Ruel Prion and Cristina Garcia, and also the people from my lab that performed these studies over the years, Tetsuhiro Kajigawa, Hui Wang, Tomoki Maekawa, Toshiharu Abe, and also Betty Hajishengallis from the Department of Periodontics that helped us with the non-human primate studies and the radiographic analysis of the bone loss. And last but not least, to thank NIH and particularly the NIDCR and the National Institute of Allergy and Infectious Diseases for generously supporting these studies for many years. And also to thank you for your attention, and I will be glad to answer questions that you may have.